Hi, I'm Kaylee Jo Starkovich, and our presentation is on post-traumatic stress disorder, also known as PTSD. The definition of PTSD is a condition of persistent mental and emotional stress occurring as a result of injury or severe psychological shock, typically involving disturbances of sleep and constant vivid recall of the experience, with dull responses to others and to the outside world. Stages of PTSD. There's 5 stages. The first stage is normal stress. The normal stress response occurs when healthy adults who have been exposed to a single discrete traumatic event in adulthood experience intense bad memories, emotional numbing, and feelings of unreality. Such individuals usually achieve complete recovery within a few weeks. Often a group debriefing experience is helpful. In the debriefing experience, you go to a treatment center, you tell them what your traumatic event was, and they talk to you and try to help you communicate your problems and your traumatic event so that you can get past it and it won't bother you anymore. The next stage is acute stress. Acute stress disorder is characterized by panic reactions, mental confusion, dissociation, severe insomnia, suspiciousness, and being unable to manage even basic self-care, such as hygiene, work, and relationships. Relatively few survivors of single traumas have this more severe reaction, except when the trauma is lasting and exposes them to death, destruction, or loss of home and community. Uncomplicated PTSD. Uncomplicated PTSD involves persistent re-experiencing of the traumatic event, avoidance of stimuli associated with the trauma, emotional numbing, and symptoms of increased arousal. Comorbid PTSD. This kind of PTSD goes with other psychiatric disorders. It is actually much more common than uncomplicated PTSD. PTSD is usually associated with at least one other major psychiatric disorder, such as depression, alcohol or substance abuse, panic disorder, and other anxiety disorders. And the last one is complex PTSD. This is found among individuals who have been exposed to prolonged traumatic circumstances, especially during childhood, such as childhood sexual violations. These individuals often are diagnosed with borderline or antisocial personality disorder or dissociative disorders. They exhibit behavioral difficulties, extreme emotional difficulties, and mental difficulties. Causes. You can develop post-traumatic stress disorder when you go through, see, or learn about an event involving actual threatened death or serious injury or sexual abuse. Some of the causes are increased risk of anxiety and depression, life experiences including the amount of severity of the trauma you've gone through since early childhood and inherited aspects of your personality. And the last one is the ways your brain regulates the chemicals and hormones your body releases in response to stress. Symptoms. PTSD symptoms are generally grouped into 4 types. There's intrusive memories, avoidance, negative changes in thinking and mood, or changes in emotional reactions. The first one is intrusive memories. Some examples of intrusive memories are recurrent, unwanted, distressing memories of the traumatic event. It's always popping up in your head and you don't know what to do because you want it out of your head, but it just won't go away. Reliving the traumatic event as if it were happening again, such as flashbacks. Upsetting dreams about the traumatic event that you just can't get rid of, you have them every single night. Severe emotional distress or physical reactions to something that reminds you of the event. So that plays a lot of roles because anything that you see could remind you of it and you freak out because you think it's going to happen again. Avoidance. Avoidance is trying to avoid thinking or talking about the traumatic event. Anytime someone brings it up, you change the subject and you try to figure out something else because you want to avoid it. Avoiding places, activities, or people that remind you of the traumatic event. So you're just completely avoiding any situation that reminds you of the traumatic event. So if you go somewhere and it looks even similar to your traumatic event, you get out of there and you don't want to be around it. The next one is negative changes in thinking and mood. This comes with negative feelings about yourself or other people, inability to experience positive emotions, feeling emotionally numb, lack of interest in activities you once enjoyed, hopelessness about the future, memory problems, including not remembering important aspects of the traumatic event because you blocked it out so well that you just can't remember it anymore, difficulty maintaining close relationships, such as boyfriends, best friends, or family members. And the last one is changes in emotional reactions. That is irritability and angry outbursts or aggressive behavior, always being on guard for danger because you're scared that anywhere you look, the traumatic event could happen again, or the sexual abuser could do it to you again. Overwhelming guilt or shame, you just feel guilty and shameful because you feel like it's your fault that that traumatic event happened to you. Self-destructive behavior, such as drinking too much or driving too fast, trouble concentrating, trouble sleeping, and being easily startled or frightened. Some therapy that you can go through to try to push away the PTSD, although it can't go away completely, is cognitive therapy. This type of talk therapy helps you recognize the ways of thinking that are keeping you stuck. So you talk about it, and then it's supposed to relieve and take off some of the stress of the traumatic event. Exposure therapy. This behavioral therapy helps you safely face what you find frightening so that you can learn to cope with it effectively. And the last one is EMDR, which is eye movement desensitization and reprocessing. This combines exposure therapy with a series of guided eye movements that help you process traumatic events, memories, and how you react to traumatic memories. A couple fun facts about PTSD. Untreated PTSD does not get better, it often can get worse. And 8% of the population has PTSD. Only half of the people that seek help get the treatment that they need. Women are twice as likely to develop PTSD than men are. About 5.2 million adults will develop PTSD in a given year. Now I'm going to hand it over to Tristan Hayes, who is going to talk about what he looked up with PTSD involving war veterans.
Hi, and as Kaylee Jo said, I'm Tristan, and I'm going to be talking about the connection between post-traumatic stress disorder and the connection with veterans and prisoners of war. And again, a quick definition of PTSD is a mental health condition that is triggered by a terrifying event which can be experienced and or witnessed. So, how veterans develop PTSD in war is by combat, which can be firefights, which are battles involving heavy gunfire and casualties, life-threatening situations where veterans can be injured or have their companions killed, and then the killing of enemies and civilians can cause nightmares and guilt. Traumatic events, explosives such as landmines, grenades, or bombs that kill and damage military soldiers and equipment, which can lead to nightmares and anxiety. The witnessing of the death of fellow soldiers can cause vivid memories and nightmares, as well that can lead to anxiety attacks and further symptoms of PTSD. Prisoners of war not only have the risk of developing PTSD from combat, but also being captured and tortured, as well as depression from being captured, and then the helplessness feeling of being a prisoner. So now I'm going to get into interviews of two veterans, and I gathered this information from one of the sources that I read. And the first veteran that was interviewed was a 24-year-old Caucasian Marine veteran who had one deployment to Iraq. His primary combat duties included going from house to house and clearing rooms one at a time to secure neighborhoods. In this line of duty, he reported being exposed to multiple life-threatening situations and firefights, witnessing dead and mutilated bodies, making many split-second life-or-death decisions, and losing two of his friends to combat-related death. After returning home to the United States, he began to experience at least 8 distinct intrusive memories and nightmares from these combat experiences. He engaged in avoidance through thought suppression, excessive work, and alcohol abuse. He avoided crowds and social situations and dropped out of college because he felt unable to focus on his academic duties as a result of his symptoms. On presentation to the post-traumatic stress clinical team, he was diagnosed with PTSD according to the SCID-1, and he scored in the clinical range on the PTSD checklist a score out of 69. He scored a score of 69 out of a possible 85. And on the BDI, which is a test out of a score of possible 63, he scored a 30. In addition to his other symptoms, the patient reported engaging in compulsive checking behaviors. He would check his front door lock 10 to 30 times a day and peeking out of his window blinds 30 to 50 times per day. The patient also reported engaging in checking behaviors whenever he had an intrusive memory or nightmare, whenever he heard anything suspicious, which was as simple as a car door closing or a dog barking late at night, and whenever he was about to relax, as a primitive measure to calm down any potential anxiety. And then the second veteran that was interviewed was a 38-year-old married African-American Army veteran who had 2 deployments to Iraq, and when presented to the VA Medical Center post-traumatic stress clinical team, stating that his commander officer recommended that he get help. The patient's primary duties during both of his tours included providing security for truck convoys by patrolling alongside them in an armed Humvee. In the course of these duties, he was exposed to multiple life-threatening situations. He witnessed the improvised explosive device detonate during a convoy. He witnessed dead and mutilated bodies, and he also witnessed a motor vehicle run over a little girl, and was responsible for checking the convoy trucks and accompanying vehicles for bombs. At the time of intake, he was experiencing more than 10 distinct intrusive memories. He engaged in avoidance through the attempt thought suppression, doing his errands late as night to avoid people, and staying home as much as possible while not at work. On presentation to the post-traumatic stress clinical team, he was diagnosed with PTSD according to the SCID criteria and scored in the clinical range on the PTSD checklist. And he scored a 68 out of the possible 85, and then on the BDI, out of the possible score of 69, he scored a 31. The patient also engaged in compulsive checking behaviors. He checked under his car and under the hood of his car for bombs every time he needed to drive, which was around 2 to 8 times per day. He expressed insight that his car checking